Hello, everybody. My name is Cristina Diaz-Navarro. I'm originally from Spain, but I have been working in the UK for the last 24 years. I am a consultant anaesthetist in Cardiff at the University Hospital of Wales, which is a really large hospital with over 1,000 beds. The health board that I work for employs 14,500 staff and provides healthcare to a population of almost 500,000 people. I'm also a simulation educator. I've been doing simulation education for the last 14 years or so, and I am the simulation lead for the Welsh School of Anaesthesia. So today I would like to share with you some of our simulation experiences in Cardiff, and also to recognise the work that has been done by our colleagues across Wales around preparation for the COVID pandemic. I think I need to disclose whatever might be relevant, and in this case it's not very much really. I'm a full-time NHS consultant. I don't do any private practice, and I have a voluntary role as the chair of the Board of Trustees for the Talk Foundation, so I've got no conflicts of interest today. Before I start giving details about the simulation work we have done, I thought that you might like to know about our COVID situation in the UK. And unfortunately, as you can see in the map, we are quite hot. And in particular, in Wales, we have had the highest number of cases per 100,000 resident population. And I thought it would be important as well to contextualize the chronology of how things started to happen, because although we first heard of COVID at the very, very end of December, beginning of January, it didn't feel quite so real for us until a lot later. In fact, we had the first COVID death in the UK on the 5th of March. On the 16th, we had our first COVID death in Wales. So we have been in Wales about a week and a half or 2 weeks behind London. And the start of lockdown was on the 23rd of March. So I was tasked with setting up a simulation for theatres on the 12th of March. But on the 13th, it became very apparent that we needed to join forces. So we did so with intensive care, emergency department, infectious diseases, surgeons. And this is quite different from normal, really. We are so familiar with working in silos by profession, by specialty, even educationally, we have different simulation settings within the same organization. But it became obvious to all of us that we needed to work together. So very much organically, we just joined forces. So the first thing we did is we gathered for an in-situ simulation training, and we started looking at, system testing really, by intubating a patient in a cohorted ward, which was ready to receive COVID patients, and try this new way of working, following all recommended infection control precautions. We had to transfer the patient through the shortest possible way to intensive care. And this involved using a lift. But eventually we made it there. And it was a really, really eye-opening experience. And I have to confess, for the previous 2 or 3 days, it had felt like a tsunami was approaching. And at that moment, as we were practicing, the reality of it hit me. And I felt quite worried about the potential magnitude of what we were going to face. And also the sudden realization that we would not achieve perfection. So in my mind, I made 2 decisions that have been very much helping me throughout this period. The first one is that we all would have to together do the best we could as clinicians and as educators. And the second decision, and what has been a big focus of the efforts, is that we needed to very much support each other through this. Thankfully, we had a lovely debriefing session led by our colleague, Sarah Catherine Cook, and she helped us deal with the emotions, point out what we were learning from the experience, and to start working out what was going to be the way forward together. So the main thing that was apparent to all of us is that there was a new solidarity at the front line, and the teams working together to start with were the emergency department, intensive care, medicine, particularly infectious diseases, but also theatre teams, including surgeons, anaesthetists, and all nursing staff. We looked at how we could make the systems work better for us with regards to the flow of patients as we were transferring them, with regards to how we were going to train staff to use different types of PPE depending on the risk of the area that they were working in. We looked at how to set up mobile emergency rapid intubation trolleys so that they could assist us in providing the best care possible wherever we had to attend patients in the hospital. And also we started planning our training with regard to faculty, resources, and keeping in mind that the learning needs were not going to be fixed, they were going to be evolving according to the situation. So we developed a collaborative approach, which very much had three main streams. The stream that I led was the rapid response training, which was delivered by clinicians from the anesthetic department and from the emergency department. And what we were trying to do was get the initial preparedness training ready as soon as possible, very much an immediate response. But there was also a sustained training stream led by the Department of Education in Cardiff and Vale, that would be upskilling doctors, and by the School of Medicine, their simulation center would be focusing on upskilling teams and helping with PPE training. Between all of us, we've managed to train more than 2,000 staff members in just over 8 weeks' time. So going back to our timeline, on the 13th, we did our run-through, and that weekend, preparation was just frantic. Not just for us from the simulation front in Cardiff, but throughout the UK. So there were websites that had just been launched that kept being populating with up-to-date information. Particularly this website has been really the guidance for our processes and procedures. It's a joint website by intensivists and anaesthetists, which is providing us with fantastic resources and is even providing guidance for development of simulation. So, crazy weekend, but we started delivering training very much on the 16th, and we delivered it for 2 weeks. And that was our rapid response training. The format of it was very thorough and quality assured, despite the haste with which we had to put it together. So we had simulation materials that were sent to staff through a simulation network that had developed organically at the time of the run-through session. We also made sure that the sessions were going to be able to be attended by a number of multi-professional staff. All team members were welcome. So we had sessions available for anybody, like the keeping safe session and the one looking at managing cardiac arrest and building resilience. And then there were more specific sessions for intubating teams around endotracheal intubation. We managed to deliver training to around 600 delegates in 2 weeks. And that would not have been possible without the help of people like Kim, who dedicated their time to just coordinating the sessions, usually scrub team, but this time educationally managing. Every morning we got together at 8 in the morning to set up or to move the props to a new area altogether, depending on clinical needs. We were doing this training in the surgical short stay unit. We were allocating sessions according to what faculty appeared on the day, and there were many changes due to sickness, amongst other reasons, and also briefing any new faculty. And it was very important that the education would be standardized and of good quality. So we had 2 hours between 8 and 10 to make sure that everybody knew exactly what they were doing. And the format, again, for standardization purposes, consisted of a set of short presentations, and then there would be a period of practice and debriefing. And the scenarios and the lesson plans had been peer reviewed and very, very detailed during the development. We also evaluated our effort after each session. And I have to say, not everybody gave us a feedback form, but we did look at what had happened over the first week, and that helped us change things for the week after. We were lucky enough that Channel 4 News came to see what we were doing and published some footage, which I'm going to share with you as well. I've selected only some short clips according to what I'm discussing with you.
Okay, I'm coming in to take over chest compressions.
It's a scenario they may have to face.
Okay, 3, 2, 1.
A patient who's had a cardiac arrest and who may have coronavirus.
Go out to the clean area.
Oh, you want me to leave?
Yeah.
Okay.
Fabulous. Great. Well done. That's brilliant.
So that's one cycle of CPR done.
Fab.
All right. So
Crash team in one room.
That's it. So that's going into the bin now.
Training in personal protective equipment in another. They are brain surgeons, A&E nurses, and in a neighbouring theatre, anaesthetists. Here being shown how to intubate a COVID-19 patient while minimising their exposure to infection.
Start ventilation, please.
They'll be using more protective masks when it comes to it, but for now they need to preserve stocks.
So we had 3 sessions and individuals could join 1 or 2 or 3 as they wanted. They would come in the morning and decide what sessions they were going to join, and we didn't really send anybody back. The first session, called Keeping Safe, provided delegates with a general perspective on what the expectation was with regards to the approaching pandemic, and emphasized how important it was going to be to work together as a team and support each other during stressful times. During stress, we don't quite communicate the same way, and preparing for that extra bit of forgiveness and leeway, accounting for other people's emotions as well as our own, was really, really important at that stage. We also provided an overview of the latest UK advice with regards to personal protective equipment, and for the purpose of standardizing the training, we included videos in the presentation so that whoever was the tutor, delegates would have the same learning experience, and then that would be followed by supervised practice on hand washing techniques and how to put on and take off personal protective equipment for aerosol generating procedures. We had another session on endotracheal intubation, which was following very freshly published guidance on airway management. This was really important to do because managing airways under COVID meant substantially change the way that we normally behave clinically. We have these deeply embedded clinical behaviors that all of a sudden had to change and become something quite different.
What did it feel like to be intubating in that team scenario and with all the PPE kit on?
And the PPE wasn't as uncomfortable as I thought it was going to be to wear.
Yeah.
Especially as a glasses wearer.
So going through this training allowed us to improve our systems, improved the equipment that we had available for our staff, and also practice the addition of those new steps to our usual clinical performance so that we would decrease the risk of viral transmission. We also, during the cardiac arrest session, updated staff on new advice as it continued to be published by the Resuscitation Council, and the shift of the emphasis from looking after the patient first to self-preservation, making sure that we were protecting ourselves and our colleagues, felt quite unnatural, and it was a really, really good thing to practice.
In 2 weeks, 600 staff will be trained like this in this Cardiff hospital alone. Wales's biggest critical care team is about to get much bigger.
All right, this isn't going to be over in the next few weeks. This is a minimum of 6 to 9 months, up to 12 months, and it's going to be really exhausting if we don't pace ourselves.
We felt it was very important not only to look after our skills, but also to build resilience and to make sure that we knew how to look after ourselves. So we included well-being advice, which had been developed by one of our clinical psychologists here in Cardiff. It is available on the website that I've put the link for So if you have a little while, have a look at it. It's well worth reading. And we also recommended the use of clinical debriefing to continue learning together, to continue improving as we went along, but more importantly, to support each other.
Everyone can feel the emotions in that? Yeah? This may be a reality. It hopefully won't be, but this is something that we have to consider going forward.
Planning for worst case scenarios while they have time.
So we collected our evaluation forms, and I have to say the sessions were very well received. We collected 189 forms over the first week, and what we heard most of was that delegates wanted more time, more scenarios, more simulation. But we had lots of very, very positive comments, which I have to say made me think how much it matters to be acknowledged. And from that point of view, I want to say to all my colleagues who devoted their time to teaching these sessions, thank you very, very much. Many of them came in their own time, some of them after having worked nights, some of them before working nights, and it was an extraordinary effort, and I'm truly, truly thankful to them. But it wasn't just the short stay unit sessions. We had also, as well as the rapid response training, sustained training that has carried on and continues to date. And that was delivered, led by two of my colleagues who are going to be joining me in the Q&A session. Dr. John Dunn is the postgraduate simulation lead for Cardiff and Vale University Health Board. And he has got a faculty group of anaesthetic trainees, clinical teaching trainees, and other junior doctors. And together they have delivered education to 600 doctors, either doctors that are being redeployed, or junior doctors, or GP trainees, or academics. And I know that they have been really, really grateful for the opportunity to prepare themselves for this new change in work. They followed a blended approach with lectures, clinical skills training, simulation scenarios, but also system testing. We have a research hospital in Cardiff, which is the Dragon's Heart Hospital, and Dr. Dan and his team did some in situ simulation and system testing there. Also joining us later will be Paul Frost, who is the Director of Clinical Skills and Simulation for the School of Medicine in Cardiff University. He works with his team in the Cochrane Education Centre, which is a fantastic facility that he has made available for free to the health board during this crisis. And what he has been training on has been donning and doffing of PPE for aerosol generating procedures, and that way he's trained more than 500 staff from 4 Welsh health boards. He has also developed a ward preparedness course, which has been delivered to more than 360 junior doctors, student volunteers, and redeployed nurses, and that has been absolutely fantastic. And the themes that they were following in the course were the ones that you can see described in the slide in front of you. But they've gone beyond that. In Cardiff University, they've also contributed to mask fit testing for FFP3 masks and have been incredibly active deploying student volunteers to help during clinical time on the wards. And I'm sure that you will want to ask Paul a little bit more about that when he joins us later. As well as this coordinated effort, there have been lots of spontaneously triggered local initiatives. And in the spirit of thanking everybody, I would like to just mention that there has been a lot of in situ training for donning and doffing of PPEs, that there have been specialist training episode sessions set up by some of my colleagues, and I would like to highlight the creativity of some of these teams. In particular, the obstetric team have set up a virtual tour of the new flow around labour ward, I think that it just comes to show how important it is that individuals will have an idea and will follow through with it. But also we've seen an increase in clinical debriefing in the emergency department, in labour ward, in radiology. Again, not just us in Cardiff. I would really like to very, very briefly mention our colleagues across Wales who have made an extraordinary effort to deliver excellent simulation sessions in their own hospitals. And the reason that they've been able to do that is because in Wales, in particularly the anaesthetic simulation training group is very, very adaptable. Our funding arrangements are quite peculiar because simulation in Wales is mostly a non-commercial activity and is led by clinicians, which means that they all promptly went into action as soon as the pandemic reached the UK. I would like to thank our colleagues in Anur and Bevan, who were the first hit by the wave and the hardest hit in the beginning. But even so, they managed to have run through sessions with the simulator to test the way that we're going to be working together. And they did simulation training, team training, and proning training on top of all the coordination and the rapid action taken. They've been absolutely fantastic. Our colleagues in Betsy Cadwaladr in North Wales have had for many years an excellent simulation setup, particularly in Bangor, and they have set up very similar sessions also for their hospitals there in North Wales. Hywelda is to the west in Wales, and not only they've set up sessions very much on the same tone as the previous ones, but they've also used their training to produce guidelines and checklists. And our colleagues in Swansea, who have been making the best of a bad situation, and you know they've had a wonderful cat, Chromie, who was self-isolating at home, coordinating simulation sessions, aiming at not just train their colleagues, but also improve the way that they work through rapid PDSA cycles. And they've delivered numerous multi-professional sessions. So, as you can see, this is a little bit about COVID, it's a little bit about Cardiff, but it's a lot about everybody else. I really want to thank again all my colleagues in Cardiff and across Wales for going well beyond the call of duty to design and deliver the training that I have presented to you. I think it's really important that we celebrate successes. I think it goes a long, long way. So do remember to thank your colleagues for the work they do. And I'll see you very soon in the Q&A session.
Hello, everyone. So happy to see you all here in our second SESM broadcast. Welcome to the Q&A session. We have a number of questions to address, but before getting into it, I'm just going to reintroduce our participants for those that may have joined us a bit later. So first of all, thank you so much to Dr. Cristina Diaz-Navarro for accepting with such enthusiasm our invitation and for continuing supporting our SESM initiatives. Cristina is a consultant anesthetist at the University Hospital of Wales and simulation education leader at Welsh School of Anaesthesia. Cristina is also the author and project lead of Talk Debriefing, and she is a confirmed speaker for our next SESM in April SESM Sabine. Also with us is Dr. John Dunn, is a consultant anesthetist and is also a foundation program director and simulation lead at Cardiff and Vale University Health Board. Together with John is Dr. Paul Frost, a consultant in intensive care. He's also the director of clinical skills and simulation center of School of Medicine of Cardiff University. And I'm Carla Sakoto. I'm serving as the head of the scientific committee of SESM since 2017, and I will be moderating this session. So we do have a couple of questions already. So maybe I could start with Mark's question, which was actually a question of my own. And I would point this to Cristina. So, Cristina, this was such a tremendous effort and an enormous endeavor. So, how did you manage to have your institutional support? How did you put all these things together to get the spaces, the staff you needed?
Okay, so for me that was fairly simple, because I work for the anaesthetic department in Cardiff, and they have been so supportive from the start. So as soon as we identified the need to deliver simulation training, not only I was given time to prepare the sessions, which I'm truly grateful for, but also it became very clear that we were going to have to cancel elective work with regard to surgical work, and that left us with theatre space available in the short stay unit. The anaesthetic department is part of the peri-operative care department and manages all of the theatre spaces, and they just offered to let us use the space that we needed. That took no time at all. It was on Friday we got together, I sent it to Paul, and we did the run through, identified the need, talked to the clinical director that can we use theatres? Yes, you can. And that was that. So that was very simple. With regard to faculty, we didn't really need that much. The emergency department and the anaesthetic department worked together to deliver the sessions, and we needed 5 facilitators per day. So one person would facilitate the PPE session, and then we had 2 facilitators per set of scenarios, one for the CPR scenarios and the other one for the intubation scenarios. And that was that, 5 people, and that got trained 60 people a day. With regard to mannequins and infrastructure, Paul very kindly lent us a mannequin from Cardiff University, and we had another mannequin that belongs to the anaesthetic department that was just transferred over, and theatres provided computers that we could put presentations on, and the surgical stay unit staff who had no clinical duties because of the change in working pattern that had already established, just offered the support and managed the influx of delegates, because the sessions were managed in an ad hoc way. So people would come in the morning and say what sessions they wanted to join, and they would be sort of helped around those by just scrap staff. The way we've worked together has been absolutely wonderful, and there have been no barriers whatsoever to any of the work we have done, certainly from my end. What about you, John and Paul? How do you feel from your end? You've been supported institutionally.
Absolutely. The medical education department took the approach that there were no specialists anymore, and that we're all members of a single team as part of the medical profession with a common purpose of looking after these patients. So I was really supported by the health board and the medical education department. And our purpose was to update and prepare doctors to work in environments that they weren't normally working in, and they may feel uncomfortable working in, or they were not accustomed to it. So what we did is quite similar to Cristina and Paul, is we made sessions available AM and PM, Monday to Friday. There is a booking system, and all doctors from all grades attended. There was no hierarchy, and we worked in teams, and that was really reassuring and very satisfying. And we did have the appropriate equipment and facilities, so we were very lucky, and our feedback was great.
So from the university perspective, collaboration has been excellent. And I think that was recognizing that we were facing a national emergency, and that brought people together very quickly. And I think too that it's probably worth emphasizing what an incredibly important resource the universities are, because of course in Cardiff we have 1,500 very well motivated students who are very keen to contribute. And I'm sure that colleagues across Europe will be experiencing much the same. And it was really just a question of trying to deploy those people usefully and give them sufficient induction so that they could be useful in the clinical environment. And I think we've done that quite well. But we had a standing start because we're well used to mass training. We have, as you say, Christine, a very good facility to provide simulation. And so it was more a question of identifying key areas in which students could make meaningful clinical contribution. And I guess for us, there were 4 areas really that were likely to be in great demand and that the students could easily undertake. One of those was PPE training that you alluded to already, particularly around donning and doffing for aerosol generating procedures. Students could very rapidly learn how to deliver that teaching and that training. Others were perhaps slightly more unusual and not so quite well known. So, for example, in intensive care, proning patients is a very important activity, as you as an anaesthetist and John will know only too well, for patients with severe refractory hypoxic respiratory failure. But actually, turning a patient over is very dependent on having teams that are trained to do that, and it requires up to 7 people to do that. And so that was another very niche role for our students. And then other roles around communication, enhancing communication with patients and medical teams, and acting as general healthcare assistants. So I guess the headlines for us was a national emergency. Collaboration was the key word for us, but recognizing that we had really, really important resources ready to deploy.
Thank you. Thank you for sharing all these very valuable lessons. We can all learn with that. And maybe the most important thing that we can take from here is that we need to really use our resources, all the resources that we have available. So maybe I can continue with Paul, because as an intensivist, you are in the front line, and Patient has made a question about the guidelines, different guidelines from different sources coming up all days. How did you manage to, to select the correct guidelines to implement in these trainings?
Yeah, I think that's a really, really important question. And I think undoubtedly, the question of personal protective equipment will be subject, in the UK at least, to an inquiry, a public inquiry, because guidance seemed to change. And there was an underlying current, I think, that the guidance was being offered not because it was absolutely the right thing to do, but rather pragmatically it's all that we could do, given the shortage of PPE. I'd like to take the opportunity to pay tribute to a colleague working in the ICU, Dr. Catherine Cook, who took this on as a project and made sure that we were very safe. And it was very interesting to us working in the ICU that the guidance that Catherine adopted very early on has only recently been caught up with by advice from Public Health England and Public Health Wales. So we were very well protected. So I think in terms of answering the question, I think you have to take the national guidance as a bare minimum position, if you like, and then think about it using your own medical knowledge and your own sources of expertise to see how you can build on that guidance and make it even safer. Another contentious area was the area around CPR, where we had one group, Public Health England, saying that CPR was not an aerosol generating procedure, and therefore you didn't need to wear an FFP3 mask and full protective equipment, whereas the Resuscitation Council in the UK took a contrary view. And I suspect that given that this is a new disease, this is a new illness, that we're kind of learning as we go along. And my strong advice to colleagues, and I'm sure that colleagues from Italy and other places like Spain that have been very hit by this will concur, is that you build the guidance as you proceed, but absolutely build it with safety in mind. How can we improve this? How can we make sure that it's absolutely safe? And not be too reliant on the first iteration and the first edition of national guidance.
I would support that. I think what was very apparent at the early stage of this disease, there was so much information coming out, and it was causing a huge anxiety among the medical and nursing staff. And I would echo what Paul says, these are the minimum requirements, to be guided by common sense and by senior clinicians. And I think we have worked very well with that here.
Thank you. Christina, would you like to add something?
I think that they have been very comprehensive. I agree with everything that Paul has said, particularly with regard to PPE. That was difficult to handle from all areas, really. And and getting something to teach that would be widely acceptable by the different groups, and that would not cause disagreement and could allow us to work together as a common group. That took quite a bit of thinking. I have to say, I found it particularly useful that the ICM website came on just on the weekend before we started the training, because most of the guidance that has been published through that has stayed consistent. It was very, very well put together. Certainly with regard to intubation guidelines, hardly anything has changed. And I think that has been quite useful for us. Also, the rapid training that we had over the first 2 weeks had very, very targeted learning objectives. So to some extent, it was slightly easier to navigate through the changes in guidance.
I would like to keep on this subject and specifically on the protection of the personnel and also protecting the participants of your training. So Mark and Mary has popped up this question. So how did you, because you had a number of people inside of a particular space, so how did you manage to protect them from spreading the virus?
I'll start answering that, because that's quite an interesting thing. Going back onto the presentation and looking through the pictures that I took at the time, I thought, oh my God, we were all together on top of each other. But the thing is, we were in the beginning of it, before the wave, there was no social distancing. That wasn't spoken about. So we started doing the sessions, and lockdown started halfway through it. So we started trying to kind of distance each other a little bit, but it really was not a priority when we started the training. It became a priority during it. And I think that probably out of the three of us, the person who has got most experience of living the transition between working the old way and working the new way is Paul, really, isn't it? You've done quite a lot of social distance training.
Yeah, so we were very fortunate in the School of Medicine. Cristina has alluded to the fact that we have a purpose-built facility. So we recognized that we could conduct training specifically around PPE in using social distancing, keeping a 2-meter rule. But you need to take a whole systems approach. So from the off, nobody was allowed to attend training self-evidently if they were pyrexial. Temperatures were checked, symptoms were checked for before they were even admitted into the building. And then we adopted a policy of using, if you like, tier 1 PPE, where every attendee for the training was expected to adhere to hand washing, wear gloves, apron, a simple face mask, before you then took them into our large teaching facility to deliver the PPE training around AGPs. So we're lucky that the facility was big enough to facilitate social distancing. But I think there are things that you can do in around these training events that make it safe. And very simple precautions, screening people as they come in, allowing temperatures to be checked, allowing symptoms to be checked for, and then allowing a basic level of PPE before you even enter the training arena is very, very, very useful. So it's possible to do, but there are some environments where it's definitely very challenging.
For sure. John?
Yes, I would agree with that. And Cristina, I did smile when I looked at the social distancing on the video. I'm a bit too close to Paul now at the moment. But and it's amazing how our attitude has changed, even from when we began the training and when we ended the training. And it's we are so conscious of social distancing now, and unfortunately our facilities don't allow us to do that in the way we wanted to do. But we were very conscious of it all the time. And it was interesting at the beginning, when we started the training at the beginning, how some people were kind of very worried, had great anxiety about coming to these sessions or even teaching on these sessions. But we did our best, and like Cristina, you have to work within the facilities you had. And thank God, everything seemed to have worked out.
Yeah, and I think that we can all take this for the beginning of the next school year and, to continue our training programs, because we all need to readapt and write protocols of new, how to engage with these training courses and classes, because we need to continue to do that. So maybe now we can shift a bit to one question that Mark popped up about the clinical debriefing, the use of clinical debriefing during in this context. And Cristina, could you just give us how did you do it? And we know that you are an expert on the talk debriefing. So could you just enlighten us how we can do that in this very stressful and complicated environment?
So we thought about delivering a structure for clinical debriefing, not for COVID, but for everyday life in 2014. And we have been working on that since. In our center, in our institution, we have implemented talk in theatre environments and in the emergency department, neonatology, and there are new implementation initiatives now in labour ward and radiology. And what we propose is that there is a set of values that are the backbone of all interactions in clinical practice, and those are respecting each other, being positive, trying to make changes step by step, being professional, and then on the basis of that, we feel that if we have conversations in clinical environments, they've got to be very, very short because we don't have an awful lot of time, and they have to be very focused. So we propose teams to first target what they want to discuss, to make things better or to celebrate successes, then analyze those, learn from the experience, and also decide on key actions to move forward. So that's what we normally do already in the area where I work. And what has happened, two things have happened. I think with regard to the briefing, one is that individuals that were already familiar with the system have been wanting to use it more, and they've been asking for support. We've got little flashcards that we use to support the conversations, and we've been asked to provide more of those because people are finding it useful to have these conversations. I have also found it useful in a different way. When we have started new procedures, or we have had to do procedures in this new way that we have to now practice with full PPE, there are new challenges that come to us, and having the opportunity of getting the group together and discussing it in a very objective and factual way, and identifying points for improvement and act upon them immediately, that has been particularly useful. And we've used that certainly within anesthetics when we have had to use these new processes in different environments, particularly in remote environments, but also when we have been dividing areas to work differently and separately, etc.
Okay, thank you. So just to refer that there are a conversation going on the chat concerning the protection of the trainees during training courses. So just to let you know that this will also be available with the recording. So just go and take a pic of what is being said there. So I would like to go now to the question of Mary Salama and also Abel Nicolau. It's more about what we can take from all of this experience and how can we take these in terms of our behaviors and attitudes, and also on the way we do simulation. So if you could, the three of you, if you could just send a key message from what we take from here, what would it be?
I think from the point of view of collaboration, COVID has been a sledgehammer really to silo working. And there's no doubt that whilst there's very bad things have happened, of course, with the COVID crisis, there's no doubt a very good thing is that the silo mentality has been broken down. And I think we're never going back to that way of working. Needless duplication of effort, needless inefficiency. And I think, for me, this has been a revelation. We've come together very quickly. We've shown it can be done. In terms of simulation, I think it's just brought it to the fore as an excellent teaching modality. The very idea that you can put people untrained into the intensive care workspace, let's say, and ask them to safely prone a intubated patient would never happen. And simulation for that particular activity has been very, very effective. So I think for me, the key messages are silo working has gone, and let's hope it's gone forever, and that simulation has been brought to the fore as a way of preparing for these sort of events.
John?
Key messages I would take away from this. I had great anxiety about opening this training to such a wide group of professions and different levels. And what I took away from this is how we work so well in teams, and how kind we are to each other, and how that silo, as Paul has already said, has disappeared, or hopefully will continue to disappear, and that we're together, we're all here together with one purpose. With regards to simulation, I think to spread the word to other specialties, anesthesia, intensive care, emergency medicine, simulation has been there for a while, but to spread it to all different specialties. And I'm now confident that the various specialties have a greater knowledge about simulation and how useful it is.
Thank you. Cristina?
So, from my point of view, in terms of behaviors, not only we have collaborated more with each other, what I have noticed is that teams have been really, really proactive in terms of developing small improvements. Every time that something was found to be useful to a certain group, multi-professionals would come together with a solution and would share those solutions. And I think that spirit of wanting to make things better together, that's so important to keep up with. And I agree, simulation has had absolutely excellent value in terms of training professionals, but also very importantly for system testing. I think that the use of simulation for system testing is becoming embedded in the way we work now, because it's proved its usefulness time and time again.
Thank you. And as Mark earlier pointed out, this is what we need to do, is to keep spreading the word about how simulation can continuously help training students, residents, and continuous medical education, but not only training, also training the systems and the organizations. So I think we have addressed all our questions. I just really need to thank to all of three of you to being here and presenting such an interesting and very valuable experience and sharing with us your so helpful ideas and suggestions and recommendations. So I would like to tell you that our next broadcast will be on June 17th. We will very soon announce the speaker. Please consult our website, SESAM website. If you are not a member yet, please join SESAM, support this initiative. And if you want to know more about our news, just sign up our newsletter. Thank you so much for being here, for participating, and take care, be safe, and see you soon.
Thank you very much. Bye-bye.